We're back with our distinguished panel of experts talking about the most anticipated clinical trials. So, Tony, I'm going to start with you. How soon can some of this information be actually integrated into our clinical practice?
Well, I think it can be available almost immediately. At JAC, we've had a policy of indicating to people who have late-breaking clinical trials that they can submit their manuscripts and get expedited reviews. So, for instance, the main COMPARE trial will be up online from JAC, and the trial, the meta-analysis actually comparing invasive versus risk stratification for patients with non-STEMIs will also be online very soon. So I think that physicians can really get these data and act upon them almost immediately.
So you're saying that what these trials come out, we can actually see them soon in press and in an online format.
Right, because I think there is a big difference, Randy, between the presentation,
right,
where things are outlined on slides, and the detailed methodology in the manuscript.
Absolutely. So, Chris, if the theme is things that are being discussed, how soon can they be integrated into clinical practice? What are you looking forward to?
Well, I think picking up on an important topic of should we follow an invasive strategy or a more selective one, a conservative strategy for unstable angina, non-ST elevation MI, Keith Fox has put together the primary data where they have 5-year outcomes, and so that's something we're always looking for. It reaffirmed the benefit of an invasive strategy with a reduction in death or MI, particularly MI, but also a very strong trend on mortality at 5 years. This is largely seen in the high-risk patients. Makes perfectly good sense, but reaffirms the guidelines now with these very long-term outcomes.
Peter?
Well, we were talking about this earlier. I have a deja vu all over again, somebody once said. But the fact is, we've been after this now for how many years? Maybe 15 years. We've known that low-risk patients you can probably be more conservative with, and the higher-risk patients need to go to the cath lab. It's nice to have confirmation of all this, and don't misunderstand me, but I think that we, in practice, already are doing what these trials are telling us to do, and that's comforting. And it's nice to know that we now finally have data that are longer term that will tell us, yes, you're doing the right thing. And for the low-risk patients, we can sort of hang out and wait for a little bit and try to treat them conservatively, but the high-risk need to go to the cath lab. Let's talk a little about the left main business, because you did mention that, Tony. And again, we've been doing a lot of left main stenting in the last couple of years since Syntax came out.
Right.
And so the question is this the right or wrong thing to do? Turns out it probably is the right thing to do. So once again, I'm comforted, but really doesn't change the way I think about, or I did think about patients last week or will next week. It just confirms what we think we are doing properly.
Well, I'd say, though, this is 5-year outcomes, and so certainly in the realm of is CABG known to be better for the long term, and can stenting compare, to have 5-year outcomes, I think, is helpful, because Syntax is at the 2-year time point now.
And in terms of left main, I mean, the number of patients that they were able to put together in Korea, where they've been doing this for a long time, where they have long-term follow-up and thousands of left main interventions, gives us a fair amount of confidence. And I kind of agree with Peter that we're not necessarily learning something that we had no idea existed, but to have that evidence.
So we're getting confirmation
exactly,
that our practice has been right.
But also we're being held accountable to have evidence for what we do, and we're getting some evidence.
The PREVENT trial is another trial that was presented yesterday, and the PREVENT trial is another one of these, I knew that before kind of trials, but as Chris pointed out to me earlier, there's nothing in a clinical trial that's not good for you. So, so the PREVENT trial was contrast-induced nephropathy. Is it better or not as good to give bicarb versus sodium chloride? And, how many times have we been over this? I think as long as you give volume to somebody who gets contrast, and it isn't cardiac cath so much, one of the things we forget is that we send a lot of patients to CT And if you do a CT with contrast,
Right,
they get more than 100 cc's, or roughly 100 cc's of contrast. And we just sort of say, oh, get one of those and don't worry about the CIN. The radiologists have to worry about that, but it's an important deal. Anyway, what this shows is no difference. And so it's the volume that seems to make the difference. And as long as we get that message across, it's a good thing, I think.
Mr. Editor, what do you think?
Well, no, I think that, for instance, the Accord blood pressure trial yesterday has provided some evidence that I think will change a little bit what many of us do, because we used to really struggle to bring blood pressure down, and now we have some evidence that if you're under 140 systolic, the patient's probably going to do about as well as they're going to do, and you don't have to risk side effects and multiple revisits to the clinic to adjust their meds. So I do think that was very valuable data.
Yeah, and there was a presentation yesterday looking at the lability of blood pressure being bad for you. So if your blood pressure is going, you add on the third med and you drop your blood pressure, that's not a good thing.
Right. Yep.
And so being more gentle and methodical and aiming for a reasonable blood pressure looks like it's the right thing from various different studies.
Absolutely. Tony, you were talking about AFib, and there's some really interesting stuff coming out today. If these trials come out in one direction, will they change our management, you think?
Well, in some respects, absolutely. If Betrixaban is superior to warfarin, we've all been looking for. Warfarin's a hateful drug, let's face it, and we've all been looking for something that's better, and that'll be a game changer of the highest proportion. I think we really do need some evidence that ablation is better than antiarrhythmic drugs.
Absolutely.
We're doing it
Absolutely.
in the absence of randomized controlled data, and I think that's critically important. The other thing is rate control. I see that as another blood pressure thing. Should we knock ourselves out trying to keep the rate low? And if we don't have to, boy, that'll be so much better for patients and for doctors.
Absolutely, absolutely. Chris, any final thoughts quickly about what you're looking forward to?
Well, picking up on the AFib, there are a lot of different pieces to AFib management of anticoagulation, drug therapy. There, is a recent drug with fewer side effects that's an option, dronedarone, then ablation, and then sorting out where in the presentation time do you come in with ablation. Is it very early or after drug therapy? So a lot of things changing. The guideline committee there is going to have a lot to work with in the next year or two.
Absolutely. Peter?
Well, overall, what I'm getting out of all these trials is it looks like we can actually use fewer medicines than so many, and that's not a bad thing.
Yes,
and it's cheaper.
Absolutely.
And our patients will love us for us. The pharmacists might not,
and
but
as
our
we're
patients
getting
will.
older and we want fewer medicines.
Absolutely. Absolutely.
Okay, well, thanks to all of you. We've got much more happening at the conference on the floor, and we're going to be bringing all of that to you. We'll be right back in just a moment.